ओके जी, तो बड़ा ही सा आसान सा सवाल है। सीएसएफ का सैंपल दे रखा है, नेगेटिव स्टेन यहाँ पर प्रेजेंट है एंड आई एम वेटिंग फॉर आंसर्स फ्रॉम यू गाइस। जैसे कि करेक्ट आंसर यहाँ पर आ रहा है कि भाई द आंसर इज क्रिप्टोकोकस नियोफॉर्मेंस। तो गाइस थोड़ा सा ध्यान से देखो, मैं मानता हूँ कि ये नेगेटिव स्टेन है, ये बैकग्राउंड स्टेन है, लेकिन इस बैकग्राउंड स्टेन में जो ऑर्गेनिज्म आपको दिखाई दे रहे हैं, क्या वो सिंगल सिंगल ऑर्गेनिज्म है या यहाँ पे तो डबल डबल ऑर्गेनिज्म भी दिखाई दे रहे हैं ना। तो क्या इसका आंसर क्रिप्टोकोकस होगा? आई थिंक this is very a question that should be picked up easily by you guys, क्योंकि एक कैप्सुलेटेड बैक्टीरिया की बात कर रहा हूँ। ये कैप्सुलेटेड बैक्टीरिया एक डिप्लोकोकस है और ये डिप्लोकोकस का जो नेगेटिव स्टेन है उसको हम मतलब नेगेटिव स्टेन से उसका कैप्सूल को डेमोन्स्ट्रेट कर सकते हैं। तो इस क्वेश्चन का जो आंसर है वो कहीं से भी क्रिप्टोकोकस नियोफॉर्मेंस नहीं है। आपको जो सिलेक्ट करना था वो था कि व्हाट इज द लीडिंग कॉज ऑफ बैक्टीरियल मेनिंजाइटिस। एचआईवी पॉजिटिव पेशेंट को भी तो मेनिंजाइटिस हो जाएगा, और मेनिंजाइटिस कौन सा वाला होगा? तो नाइसीरिया गोनोरिया नहीं बेटा। जो पहला आंसर है यहाँ पे वो नंबर 1 जो ऑर्गेनिज्म है दैट इज स्ट्रेप्टोकोकस निमोनिया। द करेक्ट आंसर फॉर दिस वन इज, अकरम वाज द फर्स्ट वन टू गेट द हिंट हेयर। तो आंसर इसका स्ट्रेप्टोकोकस निमोनिया है। एंड ये तो एक आसान सवाल है जिससे मैंने शुरुआत करी है। एंड सरप्राइजिंगली ये जो सवाल था ये तो एफएमजी एग्जाम में पूछा गया था। तो मुझे नहीं लगता कि इस क्वेश्चन में किसी भी प्रकार से गलती होनी चाहिए थी, क्योंकि जो ऑर्गेनिज्म था वो सिंगल सिंगल नहीं दिखाई दे रहा है। यहाँ पे बहुत बारी हम डिप्लोकोकस को आइडेंटिफाई कर पा रहे हैं, मतलब एटलीस्ट आप दो दो डॉट्स तो देख पा रहे हैं ना। जैसे मैं अगर इसको जूम इन करता हूँ तो आप देख रहे हैं कि दो दो डॉट्स हैं और उसके ऊपर में कैप्सूल प्रेजेंट है। तो इंडिया इंक स्टेन को या निग्रोसिन स्टेन को वी टेंड टू यूज फॉर क्रिप्टोकोकस नियोफॉर्मेंस, वो तो सही है, बट इट इज ऑल्सो यूज टू आइडेंटिफाई फॉर न्यूमोकोकस। सो द करेक्ट आंसर फॉर दिस क्वेश्चन इज ऑप्शन नंबर ए। एंड देयरफॉर जो एंटीबायोटिक का चॉइस है, जैसे ये 2 स्टेप क्वेश्चन हो सकता है आपके लिए कि क्या ट्रीटमेंट दोगे, तो आंसर चेंज हो जाएगा ना। लाइक इफ इट वाज क्रिप्टोकोकस नियोफॉर्मेस, इसमें सिंगल सिंगल ऑर्गेनिज्म होते तो फिर मैं आंसर करता लाइपोसोमल एम्फोटेरेसिन बी विद 5-फ्लू-साइटोसिन। लेकिन यहाँ पर तो द सिचुएशन इज गोना बी टोटली डिफरेंट। दैट इज कि द आंसर इन दिस केस फॉर मैनेजमेंट पर्पसेस। आप लोग कमेंट कर दो चैट बॉक्स में यस गाइस। जो एम्पेरिकल ट्रीटमेंट हम चालू करते हैं इवन बिफोर इस पर्टिकुलर केस का, मेरे पास ये इंडिया इंक प्रिपरेशन या निग्रोसिन स्टेन का रिपोर्ट आया होता, दैट वुड बी सेफ्ट्रॉक्सन एंड वैंकोमाइसिन। वैंकोमाइसिन इसलिए देते हैं बिकॉज आजकल सेफ्ट्रॉक्सन को रेजिस्टेंस मिल सकती है। सो द करेक्ट आंसर फॉर दिस पर्टिकुलर क्वेश्चन इज ऑप्शन नंबर ए। एंड द आंसर इज नॉट क्रिप्टोकोकस नियोफॉर्मेंस, नीदर नाइसीरिया मेनिंजाइटिस। हमें नाइसीरिया गोनोरिया कैसे हो सकता है यार? बता, मतलब मुझे ठीक है, मतलब दिवाली पार्टी करी है यार, बट नाइसीरिया गोनोरिया से मेनिंजाइटिस मत कराओ ना। नाइसीरिया मेनिंजाइटिस तो समझ में आ रहा है, बट नाइसीरिया गोनोरिया से तो नहीं होने वाला है। सो आई थिंक वी सॉर्टेड फॉर टुडे गाइस। द आंसर टू दिस क्वेश्चन इज ऑप्शन नंबर ए। वेलकम बैक गाइस। दिवाली ओवर हो गई है, दिवाली पार्टी के हैंगओवर से बाहर आइए एंड लेट्स मूव ऑन टू द सेकंड क्वेश्चन फॉर टुडे। यहाँ पर एक 30-year-old पेशेंट है जिसे चेस्ट टाइटनेस है, ब्रीदिंग डिफिकल्टी हो रहा है फॉर पास्ट कपल ऑफ वीक्स, एंड देन इज गिवन अ लंग हिस्टोलॉजी फाइंडिंग एंड ही सेज लाइक व्हाट वुड बी द फाइंडिंग इन दिस पर्टिकुलर केस। तो क्योंकि चेस्ट टाइटनेस लिखा था तो पहले तो मुझे लगा कि भाई दिस कुड बी अ पॉसिबिलिटी फॉर एस्थमा, लेकिन फिर ये जो बॉडी दिखाई दे रही है इसकी जो पर्टिकुलर शेप है वो तो बिल्कुल सिलेंड्रिकल या डम्बेल अपीयरेंस कह लो कि बॉडी का प्रेजेंट है। तो देन द आंसर इन दिस केस विल ड्रामेटिकली चेंज, क्योंकि इनिशियली तो मुझे लगा कि यार ये चेस्ट टाइटनेस है तो हो सकता है कि पेशेंट को एस्थमा हो, बट एस्थमा में जो क्रियोला बॉडीज होती हैं वो में भी, अब आपको इमेज दिखाऊंगा तो ब्लू ब्लू बिल्कुल बेजोफिलिक सेल्स दिख रहे होते हैं। एंड देन कुशमैन स्पाइरल्स जो है उनका तो अपीयरेंस ही फिर स्पाइरल वाला होगा ना, जो आगे मैं आपको स्लाइड दिखाने वाला हूँ। दिस वुड बी फेरुजिनस बॉडीज, और फेरुजिनस बॉडीज जो होती हैं वो मोस्ट ऑफ द टाइम हमें ऑक्यूपेशनल लंग डिजीज या न्यूमोकोनियोसिस में मिलती है। तो इट इज मेनली ऑन द बेसिस ऑफ द शेप दैट यू हैव टू आइडेंटिफाई, एंड मोस्ट ऑफ द टाइम इसका कॉज एस्बेस्टोसिस हो सकता है। इसके ऊपर में प्रोटीन की कोटिंग प्रेजेंट होगी। अलॉन्ग विद प्रोटीन ऑब्वियसली देयर इज दिस जो फाइबर्स होते हैं एस्बेस्टोस के 2 प्रकार के होते हैं। तो मोस्ट ऑफ द टाइम जो ज़्यादा डेंजरस वाला होता है उसका नाम होता है क्रोसिडोलाइट फाइबर। सो मोस्ट ऑफ द टाइम इट इज लाइक दो, क्योंकि आप पढ़ोगे 2 टाइप के फाइबर्स, तो एक होता है सर्पेंटाइन विच इज लाइक इजीली क्लियर्ड बाय मैक्रोफेजेस, और सेकंड होता है क्रोसिडोलाइट जो कि ज़्यादा डिफिकल्ट टू क्लियर होता है एंड गोज टू द लोअर लोब्स ऑफ द लंग्स एंड इज मेनली एसोसिएटेड विद डेवलपमेंट ऑफ एडिनोकार्सिनोमा एज वेल एज मीजोथेलियोमा। सो दिस इज मोस्ट प्रोबेबली एस्बेस्टोसिस के क्रोसिडोलाइट फाइबर्स, जिनकी वजह से ये फेरुजिनस बॉडीज यहाँ पर क्रिएट हो रही हैं। एंड ऑब्वियसली एस्टेरॉयड बॉडी को तो आपने रूल आउट कर लिया होगा। तो आई डोंट थिंक सो कि कहीं पे भी कोई कंफ्यूजन होना चाहिए था कुशमैन स्पाइरल्स के साथ में, क्योंकि कुशमैन स्पाइरल्स तो जो आप 2 इमेजेस यहाँ पर देख रहे हैं उसके लिए आई कैन से दैट दिस वुड बी अ वेरी करेक्टरिस्टिक शेप फॉर द कास्ट्स ऑफ द एयरवेज, दैट इज कोर्समैन स्पाइरल्स. देन एस्टेरॉइड बॉडी हम मल्टीपल टाइम पे पढ़ते हैं, बट या विद सार्गेडोसिस, बट प्रेजेंटेशन उसके साथ मैच नहीं कर रही थी. देन इज दैट eosinophilic crystals that you can see once again, that would be called as charcoal laden crystals. And जो तीसरी वाली slide है, that would be the basophilic cells that I was saying, that would be creola bodies, that would be basically the denuded cells from the airway epithelium. So the physical appearance of all of them is going to be grossly different, and that is the reason why in this case we can see gross differences. I mean, I agree, the slide in the middle would be favoring that asteroid bodies would be favoring sarcoidosis as one of the possibilities. So the correct answer for this one is ferruginous bodies. Very simple and straightforward interpretations. And now we move to the third slide for today. In this charcoal laden again for asthma, but हमारा जो केस है ना, उसमें उसने बोला कि चेस्ट टाइटनेस है, बट चेस्ट टाइटनेस तो इंटरस्टिशियल लंग डिजीज में भी हो सकती है ना. इवन अ न्यूमोकोनियोसिस कैन बी प्रेजेंटिंग विद चेस्ट टाइटनेस इन अ पेशेंट. So at this moment what you need to focus upon is the slide which is currently on the focus currently on the demonstration before you. There was a deteriorating kidney function, hematuria and proteinuria in a patient, so goes in favor of like nephritic, because hematuria bhi likha hai, proteinuria bhi likha hai, and then the biopsy finding is given. So very easy slide. I think you can pick up the crescent here, right? I mean, you can pick up that crescent of parietal cells, and along with that, then center में जो दिख रहा है, that is more pink, because वहाँ पे fibrin is leaking out of the renal capillaries. So the leaking fibrin out of the renal capillaries, because the glomerular tuft is crushed, so it's compressed. The normal integrity of the renal capillaries has been damaged, which is why वो fibrin ज़्यादा आपको pink दिखाई दे रहा है, and you can pick up the crescent there. So this would be a rapidly progressive glomerulonephritis. Again, easy pickup there. And then if you have to find out the causes, it can be immunofluorescence pattern that could be given. If it's linear immunoglobulin G deposits, then it is good pasture. If it is gonna be like granular deposits, then it could be lupus nephritis, which is one of the killers, or it could be post-streptococcal glomerulonephritis. Whereas if it is post-immune, then it would be related to ANCA. ANCA would be like conditions like granulomatosis with polyangiitis, which is the new name for Wegener's granulomatosis. So with crescentic glomerulonephritis, the slide has to be picked up. Moving to the next one, where I have a patient who has presented with a parotid swelling, and then he has given me the image, and you can identify from the image, though if I say findings it will become very obvious. So let me just write down the findings which are present here. One, I can see that there are some papillary projections. That is one finding that I can see. Along with that, I can notice that this appears to be like a cyst. So this happens to be some kind of a fluid which is accumulating here. So there is cystic lesions which are also present, and they're accumulating some material which is like homogeneous pink in appearance. And then you can see this lymphoid follicles also. So based on like the blue cells, that is lymphoid follicles and papillary projections and cystic lesions, the combination in this case would be that of a adenolymphoma. And first thought process of mine was this could be a tumor of the parotid gland, malignant also. But because he has himself said the word encapsulated, to encapsulated would mean that this would be a benign tumor. And when I say the word benign tumor, then there are only two that are to be considered: pleomorphic adenoma and adenolymphoma. Well, when I say adenolymphoma, when I say Warthin's tumor, it does not show perineural spread. Perineural spread is what you encounter with adenoid cystic carcinoma, so that is ruled out. This is obviously not the most common benign parotid tumor. And pseudopodia in the capsule, that is again a feature that is seen with pleomorphic adenoma. So I will be showing you the slide of pleomorphic adenoma also in like couple of seconds from now. But at the moment, what you had to pick up was कि जितने भी parotid gland के tumors होते हैं, they all, even the malignant ones and the benign ones, they're most of the time gonna be cold nodule, but this has high amount of mitochondria. So because of the high amount of mitochondria, oncocytes present, that is why the uptake of technetium 99 is more, and therefore the technetium 99 scan in this condition will be showing a hot nodule. The correct answer for this is option number B. The logic to be used in this case is, why I'm saying the word hot nodule is primarily because there would be more predominance of mitochondria which is present here. So you have to pick up on the slide adenolymphoma, और जो slide है आपकी that's gonna be pleomorphic adenoma, उसमें तो जो manifestations होंगे या जो features मिलेंगे वो थोड़ा सा हटके different मिलने वाले हैं. जैसे कि एक तो इस slide में जो आप देख पा रहे हैं, that is like right in the middle मैं बोलूँ तो दैट वुड बी प्रेजेंस और अपीयरेंस ऑफ ग्लैंड्स, सो दैट इज वन। उसके अलावा ये जो ब्लूइश आपको दिखाई दे रहा है, this bluish would be like mesenchyme that is present, that is basophilic ना, थोड़ा bluish color का अलग से दिखाई दे रहा है। So pleomorphic adenoma will be having multiple type of cell components present, तो glands भी present है। Then is chondromyxoid, I mean यहाँ पे he will say stroma, वो द वर्ड यूज्ड इज कॉन्ड्रोमेक्सोइड स्ट्रोमा, बट द पॉइंट इज ये जो ब्लू कलर का दिख रहा है इसमें कार्टिलेज हो सकता है, मीजनकाइमल सेल्स प्रेजेंट होंगे, तो दैट इज वाई बिकॉज देयर आर सो मेनी डिफरेंट टाइप्स ऑफ थिंग्स प्रेजेंट, कि ग्लैंड्स भी प्रेजेंट है, कॉन्ड्रोमेक्सोइड स्ट्रोमा भी प्रेजेंट है, दैट इज वाई वील बी सेइंग द वर्ड प्लियोमॉर्फिक एडिनोमा in contrast to adenolymphoma, where you can notice this germinal follicles in the periphery of the slide at about 6 o'clock position. So the first slide, which is currently on the focus before you, this would be a pleomorphic adenoma. The word pleomorphic itself is self-explanatory. इसमें multiple type of tissues present है, gland present है, stroma जो है basophilic है, chondromyxoid stroma उसको बोलते हैं. Then we also have myoepithelial cells which are relatively flattened ones, whereas on the right hand side I can see lymphoid follicles, I can see acini-like of an appearance, there are papillary projections which are present, so that makes me help identify that I'm dealing with the case of adenolymphoma. तो स्लाइड देख के शॉर्टेस्ट पॉसिबल टाइम में आपने कैसे डिफरेंशिएट करना है, दैट इज व्हाट आई ट्राई टू एक्सप्लेन फॉर द टू कॉमन बिनाइन ट्यूमर्स एंड बोथ विल बी इनकैप्सुलेटेड, जबकि कैंसर में इट विल ऑलवेज बी अ लाइक अ ट्यूमर दैट विल बी स्प्रेडिंग यू नो फ्रॉम द सुपरफिशियल लोब टू द डीप लोब ऑफ द पैरोटिड। सो द करेक्ट आंसर इन दिस केस वाज ऑप्शन नंबर बी। जितने भी पैरोटिड ट्यूमर्स है सभी में आप पढ़ोगे कोल्ड नोड्यूल है, ओनली वन विद अ हॉट नोड्यूल इज द वन दैट आई हैव डिस्कस्ड। Next is a peripheral smear where you can notice this ring inside the red blood cell, and this ring is the one that would be called as a Cabot ring, and this Cabot ring would be present in multiple conditions. Is asking you where would this not be present. This Cabot ring is basically a remnant of the mitotic spindle and would be seen in those conditions जहाँ पे RBC formation will be affected. One of the best examples for that is like vitamin B12 deficiency. So megaloblastic anemia, the moment I say, you know that this would be a cause which is responsible. So yes guys, hit the comment button. Cabot rings would not be seen in which of the following conditions? Well, I think question and not. सो कैबॉट रिंग्स तो विटामिन B12 डेफिशिएंसी में भी होते हैं, फोलिक एसिड डेफिशिएंसी में भी प्रेजेंट होते हैं, तो जो बच गया वो दो ही है ना, दैट इज गोना बी सिड्रोब्लास्टिक एनीमिया, देन इज गोना बी माइलोडिस्प्लास्टिक सिंड्रोम। तो यस गाइस, यू कैन हिट द कमेंट बटन। द क्वेश्चन इज किस में नहीं मिलता है, तो आई सेड इट्स अ रेमिनेंट ऑफ माइटोटिक स्पिंडल जहाँ पे आरबीसी फॉर्मेशन डिफेक्टिव होती है, दैट इज फोलिक एसिड डेफिशिएंसी, दैट कुड बी फोलिक एसिड डेफिशिएंसी, B12 डेफिशिएंसी, माइलोडिस्प्लास्टिक सिंड्रोम। कहाँ पे नहीं मिलता है यार, आसान सा सवाल है। सिड्रोब्लास्टिक एनीमिया तो हेम के फॉर्मेशन का डिफेक्ट है ना, उसमें तो आपको मतलब यू विल बी एबल टू सी पैपनहाइमर बॉडीज ना, उसमें तो कैबॉट रिंग्स नहीं होते हैं। सो द करेक्ट आंसर फॉर दिस वन इज ऑप्शन नंबर सी, क्योंकि जब भी हम सिड्रोब्लास्टिक एनीमिया के बारे में पढ़ते हैं तो उसमें तो देयर इज अ डिफिकल्टी इन इनकॉर्पोरेशन ऑफ आयरन इनटू हेम, तो अगर आयरन का इस्तेमाल ही नहीं होगा, इफ आयरन विल नॉट बी यूटिलाइज, आयरन विल अपीयर ब्लू इनसाइड द आरबीसी, दैट ब्लू स्पॉट्स इनसाइड द आरबीसीज आर व्हाट आर कॉल्ड एज पैपनहाइमर बॉडीज। सो द करेक्ट आंसर फॉर दिस क्वेश्चन इज ऑप्शन नंबर सी। व्हाट यू हैव टू बेसिकली figure out is that this is the season when exam would be coming, so you just need to pull up your socks and get into the right groove so that you can get to the right answers. तो मतलब वो ठीक है, थोड़े easy वाले भी हैं, but then I try to put up a mixed bag question where some you will have to rack your brains and like work out the information for them. So we are sorted for question number 5 guys. Let's move to the next one. This is a neurodegenerative disorder, 2-step question. ये जो दिख रहे हैं ये तो RBCs हो गए, so that is easy to identify. ये जो बैकग्राउंड में दिख रहा है इसको हम बोलते हैं these are gonna be like neuropils, right? Neuropil would mean that this would be those I can say dendrites or axons का जो appearance है, that would be called as the neuropil, and then inside you can see a eosinophilic body with a halo present. तो क्योंकि यहाँ पे halo भी present है और हेलो के साथ में eosinophilic body present है, so therefore the interpretation in this case would be a Lewy body, and since I've said there is a Lewy body which is present here, so therefore the diagnosis of this patient would be kept as Parkinson disease, and therefore for Parkinson disease the management that we'll be using would be levodopa. So the answer for this will turn out to be option number A, and the main thing to be identified is that this is a eosinophilic body with a halo around it which is present in the cytoplasm of the neuron, which is why the answer to this question will turn out to be option number A. So good going guys at the moment. नेक्स्ट इज अ स्लाइड जिसमें ब्लैक ब्लैक दिखाई दे रहा है, तो ये तो बहुत ही आसान है. दिस वुड बी अ Mason Fontana stain, and the moment I say that black, the moment I say the word Mason Fontana, you would be able to identify that what is the problem going on in this patient. That is, what is the product that we are trying to demonstrate in the skin lesion? That would be melanin. The correct answer for this one is option number B. So pretty straightforward one that had to be picked up in this case. Okay. Next is a question on a person who came for a routine liver ultrasound, and there was a mass that was detected. So we thought it would be a cancer, it could be hepatic adenoma, it could be a fibronodular hyperplasia, and therefore we've done a biopsy. Now the biopsy में जो आप देख पाएंगे, the moment I'm able to zoom in is one, there would be like, fibrous material present. So this is a fibrotic strand, this is fibrous material, fibrosis present in the middle, which I can call as a central scar. And what you can also pick up here in this particular part is the proliferation of the bile ducts. Bile ducts भी हैं, blood vessels भी हैं, उनका proliferation भी ज़्यादा हो रहा है. So combination of fibrosis, एक strand present है, and then bile ducts का proliferation is present. That would make up the diagnosis in this case as FNH, that is focal nodular hyperplasia. That is, FNH is an easy pickup for this one, because one, we can pick up the fibrosis and the scar, and second, we can pick up the proliferation of the hepatocytes. We can also pick up a proliferation of the bile ducts and proliferation of blood vessels as well. Hepatocytes यहाँ पे बिल्कुल normal दिखाई दे रहे हैं. So there is no neutrophils, no like organism. There is no neutrophils. There is no extensive cellular infiltrate that is present, which is why, like, the abscess part is something that I can rule out in this particular case. And yeah, because the question was on a female, I was thinking about hepatic adenoma also. But then hepatic adenoma will usually be having a well-defined capsule, and hepatic adenoma will not be having that fibrosis present in the middle as is present in this case the fibrous strand that can be picked up. So this is like a focal lesion that is being identified. The correct answer for this one is option number D. Great. We move to the next question. That would be this young lady, she came with neck swelling, and then category B symptoms are described. Hemat में जो category B symptoms होते हैं, they would be like identical to what we get in tuberculosis. There would be fever, night sweats, weight loss present, and we did a excision lymph node biopsy. Now he says which of the following is correct about this condition. So you can easily identify that RS cell or Reed-Sternberg cell, that I don't need to highlight, that Aulai appearance that is present. What he says is what is the most appropriate one for this condition. So yes, guys, you can quickly hit the comment button for whatever you think is the appropriate one. And Hodgkin's lymphoma, because what we are considering at the moment, will not be spreading to multiple group of lymph nodes. बच्चे, ऑप्शन नंबर ए इज नॉट द आंसर, क्योंकि वो तो नॉन हॉजकिंस लिम्फोमा के साथ होता है ना, जो एक साथ मल्टीपल ग्रुप ऑफ लिम्फ नोड्स में प्रेजेंट करता है नॉन कंटिगुअस स्प्रेड के साथ में, या तो कंटिगुअस होता है, और वॉल्डर रिंग की इन्वॉल्वमेंट भी नॉन हॉजकिंस में होती है. तो ए, बी और सी तो तीनों ही नॉन हॉजकिंस लिम्फोमा के फीचर है. हॉजकिंस लिम्फोमा होता क्यों है? सो द फर्स्ट लाइन दैट आई हैव सेड इन हॉजकिंस लिम्फोमा इज कि हर कोई रीड-स्टर्नबर्ग सेल के पीछे भागता है, वही वो पूछता ही नहीं है. वो पूछता है हॉजकिंस लिम्फोमा के लिए दो जो कॉमन सवाल मैंने देखे हैं जो कि पूछे जाते हैं NEET में भी, FMGE एग्जाम में भी. एक तो कि इट कैन बी अ पैरानियोप्लास्टिक मैनिफेस्टेशन रिलेटेड टू द हॉजकिंस लिम्फोमा की पैरानियोप्लास्टिक मैनिफेस्टेशन कैन बी नेफ्रोटिक सिंड्रोम. दैट इज वन. And the second aspect is कि क्यों होता है, that is a chromosomal amplification, that is chromosome 9 24:1. So the correct answer in this case is option number D. Hodgkin's lymphoma जो है उसका तो स्प्रेड जो होगा वो कंटिगुअस होगा, वो तो अनैटमिकल बाउंड्रीज को रिस्पेक्ट करेगा. इट्स गोना मूव फ्रॉम वन लिम्फ नोड टू अनदर इन अ वेरी रिस्पेक्टफुल फैशन. नॉन हॉजकिंस इज लाइक दैट ब्रूट which is gonna move on from one group of lymph node to another. So the correct answer in this case is sorted to be option number D. Let's move to the next one. ये तो बहुत ही आसान है. There is slow growing lesions on the arm of the patient that occasionally bleeds. और फिर वो sun exposure की बात कर रहा है, and you can see the keratin pearls which are present here. So I mean, this is something that I think you would have been able to solve, even me having to say the options present here which will turn out to be squamous cell cancer. But yeah, I mean, it's gonna be a mixed bag where you're gonna get a question where you have to think, and then there would be one which will be a spot one. So timer लगा के हम ऐप में questions करते हैं, whereas actuality में you may not be having to use the timer because every question deserves the answer on the merit. Some questions in the paper you'll be able to solve in like 15 seconds. Some are gonna take like maybe 2 minutes, and you have to think about them. So this was an easy one, and we move to the 50% midway. I mean, we are at the 50% mark in today's discussion. This patient came with shortness of breath and joint pain, the creps which are heard, elevated BNP levels. So they tell me that there is some kind of heart failure that is going on in this patient, and it shows that there are characteristic cardiac lesions which are present. So what is the characteristic cardiac lesion? Well, I can see these would be those histiocytes, right? These would be those Anishko cells. We can see the myocytes. And between the myocytes, we can see these Anishko cells. We can see a bit of fibrinoid necrosis. So the case that he's given to us is that of rheumatic fever and is gone into heart failure in any patient of Ashkoff body, basically. So how do you manage this patient? For treatment of carditis, we have to give steroids in a patient. The main drug for management of carditis is steroids. So steroids have to be given, but there is heart failure, which is also described. So I will be giving steroid treatment also. I will be using heart failure treatment also. Benzathine penicillin is obviously for prevention in this case. But along with this, the basic point is that you have to treat the carditis component with steroids, and you have to treat the pulmonary edema or the heart failure finding with diuretics. So the correct answer in this case will turn out to be option number D. It's just that you have to pick up what is given in the question: carditis component, heart failure, along with rheumatic etiology, and you can nail down to the final interpretation in this question. Next is a patient who has come with hemoptysis. And in this patient hemoptysis, there is this egg of a fluke which is present in the sputum of this patient. What I'm talking about at the moment is a guy who loves to eat seafood. He ate crabs, and these crabs that were cooked were not of good quality. So therefore, he ingested, that metacercariae, which ultimately resulted in development of a lung fluke in this chap. And because of this lung fluke, what happened was that there would be hemoptysis even happening. So this golden yellow egg that you are seeing is a Paragonimus westermani. And for the management of this lung fluke, which is caused by endemic hemoptysis, we shall be using praziquantel. The main reason in this endemic hemoptysis is the infection with Paragonimus westermani. So we are sorted for this question, which was, I think, an easy one to be picked up. Great. Next is the onion skinning. We read about onion skinning multiple times, and this time the onion skinning is given in the lymph nodes of a patient. The moment, even if that onion skinning word was not given, I deliberately kept it so that I could just highlight that point before you. But every time you read about an onion skinning, that too with respect to a lymph node, there is only one possibility that is to be think of. That would be Kaposi herpes simplex virus linked manifestation that is called as Castleman disease. And Castleman disease would be related to lymphomas. This would be, interleukin 6 excess, which contributes to this particular appearance. And in Castleman disease, the incriminating virus that is responsible happens to be human herpes virus 8. The answer to this would be option number B. Okay. Next is that classical banana-shaped gametocyte that we see with falciparum malaria. And anybody in India with falciparum malaria, we have to give artesunate. So this was a quick revision for you. Banana-shaped gametocyte for falciparum malaria, artesunate, and sulfadoxine pyrimethamine would be used for management of this patient. You need to keep the comment buttons on. Just keep up with the tempo in that case. And now we have a histopathology slide in which there was no history that is given, but you can pick up is a big macrophage. I'll zoom it in, and in this macrophage, what you can notice is some maybe the resolution part will get hampered if I zoom in too much. But yeah, I think you can pick up that double dot which is present here. The moment I say the word double dot present or that dot dash present, you know that you are dealing with Leishmania donovani. So the word is double dot, which is to be identified here. That would be Kala-Azar, and therefore the answer in this case will turn out to be amphotericin B. The correct answer in this case is option number A in this case. Now, because this question has been repeated multiple times, so I've given the 3 slides together where they'll give you a macrophage. In one, you will be able to pick up the double dot sign. So the double dot sign will immediately tell you that you are doing a test. Even in this guy, that's gonna be RK39, and that RK39 antigen would help you in being sure about the diagnosis for Leishmania donovani, where there would be like LD bodies that are present. But in case they give you a macrophage and this particular chap is having that halo present, like in this case, there is some halo present around the inclusion, the bluish inclusion inside the cytoplasm. So the disease that we're thinking upon in this particular case would be histoplasmosis, where we might be using itraconazole. And the third one that I want to say is like a macrophage, which is totally cluttered with large number of organisms, which would be having that safety pin appearance. And the moment I say the word safety pin appearance, you can identify that I'm talking about donovanosis. So 3 slides on a comparison mode. One is that safety pin appearance for donovanosis. Then is that halo in these single inclusions that are present for histoplasmosis. And the third one is obviously that Leishmania donovani. So the comparisons are the ones which are to be remembered. If you just zoom in, the double dot appearance versus the halo that is present with the single body versus the third one where a safety pin appearance is present would help you identify the final inclusions, and therefore like it can be two-step and they can ask you the treatments as well. And in this one it was easy to identify, that is double dot or dash dot I can say, that would be for amphotericin B as an answer. Okay. Next is a patient who came with these patches on the chest, that patches on the chest and back. Okay, that worsen with sun exposure. Indian patient with patches on his chest and the back. Either it's gonna be tinea or it's gonna be a lesion maybe related to leprosy. And because he has himself helped you out with the fungal elements word written, you know it is tinea versicolor. It would be that spaghetti and a meatball appearance that you encounter with tinea versicolor. The spaghetti and meatball appearance is very hard to miss. For this particular case, the answer here would turn out to be option number C. Okay. Next is a biopsy specimen of a bone marrow, and you can notice the eccentric nucleus. I mean, the nucleus is having very coarse chromatin, the thick chromatin that you can see. I'm calling it coarse chromatin, and at the same time, it is eccentric nucleus which is present. So the movement, yeah, Malaysia, furfur, yes, Cav, you had a point there. So eccentric nucleus, big macrophages present. The first thing that comes into mind would be, because I'm saying the bone marrow has to be a plasma cell. So this was like a dead giveaway for the answer in this question. Okay, so now I have a patient who's having low hemoglobin, RDW is increased. So reason for increased RDW can be a dimorphic cell population. And if you look at the cells, I can say the cells are smaller in size. So microcytic hypochromic anemia is present here. And one of the leading causes of this in India would be iron deficiency anemia. So my objective would be to identify, okay, what could be the reason behind it. So it says like which of the following does not play a role in assimilation of this deficient nutrient. So in iron assimilation, on the luminal side we have DMT1, that is divalent metal transporter. On the when divalent metal transporter, the iron will go inside, then it is transported to the blood vessels. That transport to blood vessels will be via ferroportin, and when the iron is coming inside in the form of Fe2 plus, it has to be converted to Fe3 plus with help of ceruloplasmin. So ceruloplasmin also plays a role in conversion of Fe2 plus into Fe3 plus, so that it can bind to transferrin and then can be transported to the tissues. So here is saying which does not play a role in assimilation of this deficient nutrient. Haptoglobin has no role to play, man. I mean, you all know from pathology that haptoglobin is a mop which is all related to hemolysis. When it say like person is having intravascular hemolysis, that is where haptoglobin will come into picture. So the correct answer in this case is option number D, because it's a not question. Haptoglobin tends to become less in all types of hemolytic anemias and becomes absent in case of intravascular hemolysis. So DMT1, I repeat again, is on the luminal side. Ferroportin is on the side where the blood vessels would be present, and when Fe2 plus comes in, it needs to be converted to Fe3 plus. So ceruloplasmin also plays a role in assimilation, that is like utilization of iron by the body, but what will not be used would be haptoglobin. Okay, next you can pick up that metachromatic staining, and this metachromatic staining is very characteristic for Corynebacterium diphtheriae. So the organism is very like easily identifiable with that purplish this is Albert stain basically, where you have that purplish granules in the periphery and the bacteria would be appearing green in color. We call it Chinese letter appearance, cuneiform appearance, whatever. But then Corynebacterium diphtheria, metachromatic staining is the organism that is given here, and is asked you what is the cause of death in this case. Well, whenever we talk about the cause of death, guys, then the bottom line is whenever we are talking about the cause of death, then it's not type 1 respiratory failure. I mean, why does diphtheria cause death? I think it's a very easy question. In diphtheria, the toxin which is produced causes damage to the heart. So the death in this case would be due to myocarditis. It is not gonna be answered by you as type 1 respiratory failure. I understand you are thinking about fascial diphtheria going into laryngotracheal diphtheria, choking the patient, causing hypoxia. So that is why type 1 respiratory failure was coming in. But like actually in diphtheria, it is not always going to be laryngotracheal diphtheria, which is going to choke the patient and contribute to a stridor. So if that was the case, even hypoxic seizures would have been the correct answer, because if I have a laryngeal diphtheria, then it will choke the patient. So hypoxia will cause, choke the patient will cause hypoxia, and hypoxia will cause seizures. The correct answer in this case would be answered as myocarditis, which is one of the leading causes for diphtheria. So we just need to watch out for those questions which tend to pull down the score. Obviously, there would be some sitting easy ducks that would be given. So everybody is able to get up to that score of 40-50%. But after that, like, you have to pick up the questions which are like a little, not I would say difficult ones. It is just that you have to keep the presence of mind and come to the correct answer. So we come to the last one, which is like first line of the MCQ, solving it only, painless mobile breast lump in a patient, and then the core biopsy, you can see the clefts which are present here. That is one. There are slit like ducts which are present. So clefts which are present, slit like ducts that are present, and that tells me that I'm dealing with a fibroadenoma, which happens to be a benign tumor. Just go by simple. No, it's like a painless mobile breast lump. We call it breast mouse, and in breast mouse you get is clefts that are seen. Like you can see multiple clefts, and along with that, like multiple ducts are also visible. Slit like ducts are present. So the combination of the clefts and slit like ducts, this would be a feature, and a lot of stroma. The pink thing that is present in between is like a lot of abundant stroma present here. That makes it a intracanalicular fibroadenoma. So this was a quick one, guys. I think at least out of 20, 17, 18 are the ones that you should be getting correct. And if you get anything lesser than this, then that means that the reflexes are relatively slow. So it was a quick session that we did today. 20 odd MCQs, and I think getting to a score of about 70 to 80% makes sense with these kind of easy kind of questions. So do try to just scroll through the video fast and check out whether you able to get to that mark or not. And I would like you to comment below in the comment box regarding the final score that you got. So just scroll through the video once and comment regarding how much score that you get. Not that I wanna say anything with respect to your scores. It's just being honest. When you write down those marks, it's gonna give you like, okay, I need to improve myself. If I'm getting like 15 or I'm getting a 16, then I need to push it, because that could be that margin that would help me sail through in the final go. So fine, guys, thank you so much. And it's never too early. I think, in my opinion, you have to be mentally aggressive to be able to get to the final stage in the exam. So great, guys, great going. But yeah, that 11 or 14 are good answers. Nothing, I don't criticize you. That's a very, very good outputs that you've done. But yeah, you just need to push yourselves a little bit more. So yeah, we discussed a couple of questions that have come in INI-CET also. So yeah, Tashugamu, do check out how much did you get in this case. And we do have a session lined up. The LLR session for INI-CET is lined up for 5th of November. So keep tuned for that. Thank you so much, guys, and see you again, and keep reinforcing the data that you were not able to score in this one. Bye-bye. Take care. God bless you. No, there is no syrup. It is sublingually given. No, it is sublingual tablet that would be given. Okay. Bye-bye. Take care.